This meeting is being recorded.
Good morning, everyone. Happy Wednesday. So great to see your faces. Oh, Ronnie, you're all dressed up. I like the tie. Fancy.
And
Hi, Dr. Anderson.
yes, I just jumped on. You want to jump on?
Hello, this is Christine. Can y'all hear me?
Great. So in the chat, hopefully y'all can see the screen. Go ahead and say hello. Tell me how your morning's going. And tell us favorite summer tradition or something you're doing this summer that you've never done before and you're looking forward to. It's hot in South Carolina. Let's just embrace it and either go away to somewhere cooler and better, or enjoy our time on the beach in beautiful sunny South Carolina. So in the chat box, tell us your favorite summer tradition, why you're here. Welcome, welcome. So glad that you all are here with us today. And we have Dr. Ira Murray here up at the top. I'm going to pin you, who's going to speak with us in just a minute. And we're looking forward to having him. So thanks, everybody. Nice to see everyone in the chat. Hi, Hope. Hi, yes, great. Hi, Cindy. Great, so later today, and we'll go over this in a little bit, later today we're gonna do a little bit about the DEI project guide because we need to figure out what works for that. This is our cultural competency session, but we're really talking a little bit more about a framework that Dr. Murray is gonna present to us about cultural, capital cultural wellness. So tell me the framework name again, Dr. Murray.
It is community cultural wealth.
Right, community cultural wealth, which I think is a much better way of thinking about cultural competency, and it's a much more realistic and valuable way of thinking about things. So we're looking forward to having a great discussion. Good morning, good morning. I love, Erica taking 2 vacations. That's what I'm talking about. Yes. Anytime in South Carolina travel, we love it. Chrissy, thanks, we can get you dialed in. So good morning, everybody. So just to let you know where we are here, session 3, we'll be here till noon. And then we're also really talking about the DEI project plan and setting us up in session 4 to talk about community partnerships. And we're gonna ask some of y'all to share in that session about your successful community partnerships and what that looks like. And we're gonna have the fantastic Dr. Cabrina Bass to help moderate that discussion. So we'll be in touch with you guys to figure out what community partnerships are going to be great for session number 4. We're also going to have more, we're also going to have a little bit more guidance on that, which you'll hear a little bit later in the day. So of course, as always, please, participate in the chat. Make sure that during our discussions today that you do a little step up, step back, like we discussed in the first couple meetings, where if normally you are a talker in these meetings, please maybe take a couple steps back and let other team members talk from your hospital system during the sharing portion. And vice versa, if normally you're a little quiet, please go ahead and speak up today. So we're gonna talk about successes and challenges with health equity, which we know can be incredibly complicated. So with all of that, I'm going to introduce Dr. Ira Murray. Do you want to share your screen, sir, while I introduce you?
Sure, let's see if it works.
Groovy, let's do it. So Dr. Ira Murray, he was named President and Chief Executive Officer of the United Way of the Capital Area, which is Jackson, Mississippi, in July of 2018. Prior to that, he began his United Way career in 2005 as a community fellow with the United Way of America. And at the end of his fellowship, he agreed to remain in Jackson as a vice president of community impact at the United Way, a position he held until 2014. During that tenure, he led the organization's transition from a traditional pass-through organization to one that really focused on addressing large-scale community issues through community and collective impact partnerships. Dr. Murray earned a Bachelor of Science degree in Business Administration from Florida A&M. He has a Master's of Education from Vanderbilt University's Peabody College and a Doctor of Philosophy in Education from the University of Pittsburgh. He's an educator, education scholar, writer, and advocate with expertise in issues of race, equity, and achievement in urban schools, school districts, and communities, which is incredibly valuable for us to hear from and about today, because I know a lot of y'all work with schools as your community partners. He currently chairs the United Way Black Professional Leadership Alliance and serves as a member of 100 Black Men of Jackson, the United Way Worldwide Equity Advisory Council, and the board of directors of Excel by 5 and the Mississippi Early Learning Alliance. All right, with your community advocacy and volunteerism, sir, congratulations. He's also a member in good standing of the American Educational Research Association. He's featured in numerous news publications and outlets and has testified before the Mississippi State Legislature on issues including equal pay for women. He's the recipient of numerous awards and recognitions, including the 2019 Early Career Alumni Award by the University of Pittsburgh School of Education, and was named a 2013 Mississippi Business Journal Top 40 Under 40 Business Leader. He lives in Madison with his wife, Tracy, and daughter, Amani. So thank you so much for being here.
Thank you for having me.
Great.
All right, so thank you everyone and good morning. I'm going to put myself on a timer because I can talk like most academics can. So I'm going to make sure I am respectful of everyone's time. What Katie didn't mention on my bio, and I appreciate the introduction, Katie, was probably the most important part, which is I am born and raised in Columbia, South Carolina. I am a graduate of W.J. Keenan High School, which is, I would say, the best high school in the state of South Carolina, with all due respect. And my parents still live there. I still have a lot of family in the area. My mom is from Fairfield County. My dad is from Bamberg County. And so South Carolina is still near and dear to my heart. And so, you know, when I was presented with the opportunity to engage with you all today, I jumped at it. You know, this is something that I love to do as much as I can help my home state and my hometown. I'm very proud to do so. So thank you for having me. So today I wanted to talk a little bit about community cultural wealth and as it relates to advancing rural healthcare. Now, one of the things I will say is I am not an expert in healthcare. But what I think is really important is that the issues we're talking about cut across so many different disciplines. And the idea of being culturally responsive, of being able to understand the wealth of communities is something that applies across any discipline. And so I come at it from an education background, I come at it from a community development background, but I think that what you'll hear about today is pretty relevant to what you're experiencing. So let me make sure my slideshow is working. All right, here we go. And then also I wanted to make sure that we didn't just have the run-of-the-mill type of cultural competency training. I know when you hear the term cultural competency training, you know, your head's about to explode, right? Because you think it's going to be pretty much the same concepts. But what I wanted to talk about more broadly was how we think about culture and how we really appreciate the myriad aspects of culture that not only are assets, but also help to build the wealth of communities. And I think, you know, in my experience, when we plug into that, that's when we have the most impactful engagement with communities. It's when we have the most trusting relationships with communities. And it's where we can have the most important work done. So just a quick agenda. Katie has already introduced me, so I won't have to go any further on that. I want to jump right in because we have limited time today on this concept of community cultural wealth, really, and how it's built off of the idea of cultural capital. And then go into a little bit of conversation about what this means in terms of how this connects to healthcare, giving you an opportunity to kind of think about and share and ask questions about what this could mean in a healthcare context. And then I also wanted to make sure that we had some time to talk about how this is integrated or can be integrated into building a strong corporate culture that is centered on recognizing and understanding the wealth of cultures and communities. All right, so before we dive in, there are two things I really want to talk about before we dive in. One is tangentially related to what we're talking about today, and one is directly related. The first is I could not start this presentation today without first acknowledging the 21 lives that were lost in Uvalde, Texas yesterday. 19 of them children, elementary school children. I have a daughter who just last night graduated from pre-K, and so she'll be going to an elementary school in the fall. And so, that really hit home for me, knowing, that these children, these parents dropping their children off to school and not being able to pick them up, not being able to, in some cases, even identify them. And I think that's something we need to, as a society, really get our hands around. And I wanted to make sure that we honor those children and those teachers today who lost their lives. I keep behind me, if you'll see behind my left shoulder, a picture of Mother Emanuel Church in Charleston in my office in Mississippi, as a reminder that we cannot take issues of safety, of community health, of mental health for granted. And that's something that I try to center on every day. Now, with that said, let's dive into this work. So last week, some of you may be familiar with, particularly if you're on social media like I am, may be familiar with a little bit of controversy that occurred last week. And that's with a certain senator from the state of Louisiana. Senator Bill Cassidy from Louisiana, who is, by the way, a LSU trained physician, said the following about, and I'm going to see if I can, get this. I need to change my view on here. I can't see the whole. Here we go. And Senator Cassidy made the following comment in an interview. He said about a third of the population, and this is in the context of talking about maternal mortality in the state of Louisiana. And he said about a third of our population is African American. African Americans have a higher incidence of maternal mortality. So if you correct our population for race, we're not as much of an outlier as it otherwise appear. For whatever reason, people of color have a higher incidence of maternal mortality. Now, many people, including myself, were troubled by these comments, and not simply because Cassidy himself has worked with underserved patients in a state with some of the worst health outcomes in the US, but also because of the troubling idea that Black maternal mortality is this esoteric concept that's indiscernible to even trained public health officials. When in fact, several studies have shed light on the issues that Black women face regarding Black maternal care, both pre and postnatal. And moreover, all one would need to do is talk to Black women, and they will freely tell you about the challenges they face and the reasons that so many Black women do not make it to or through childbirth, including medical professionals not taking their claims of pain, discomfort, and pregnancy abnormalities seriously. And so I argue that at the core of this inability to understand Black female pain is a lack of willingness and or ability to understand the cultural experiences of many Black women and how those experiences have shaped their interactions with, attitudes about, and ability to navigate healthcare systems in the US. And I would also posit that this extends not only to Black women, but to non-dominant communities in general. And so this is what brings me to the idea of community culture. Because at the core of understanding how to partner and engage with communities about issues of health outcomes and health access is first understanding the culture of those communities and valuing the different ways that people express themselves, come to learn and come to know, and the way that people navigate throughout the world and throughout society, knowing that it can be different depending on the nature of the community, whether it's urban or rural, whether it's people of color or people who are white, whether it's people from different nationalities and different cultural backgrounds. So some of you may be familiar with the concept of cultural capital, which was first introduced most notably by theorist Pierre Bourdieu. Bourdieu argued that cultural capital is the accumulation of cultural knowledge, skills, and abilities possessed and inherited by privileged groups in society. And essentially, Bourdieu argued that the knowledges of the upper and middle classes are considered capital, valuable to a hierarchical society. And if one is not born into a family whose knowledge is already deemed valuable, one could then access the knowledges of the middle and upper class and the potential for social mobility through formal schooling. Bourdieu's theoretical insight about how a hierarchical society reproduces itself has often been interpreted as a way to explain why the academic and social outcomes of people of color and other non-dominant communities are significantly lower than the outcomes of white middle class and upper class communities. The assumption follows that non-dominant communities, quote unquote, lack the social and cultural capital required for social mobility. And as a result, social institutions often work from this assumption in structuring ways to help disadvantaged communities whose race and class background have left them lacking necessary knowledge, skills, social skills, abilities, and cultural capital. Now, the concept of community cultural wealth, however, shifts the center of focus from dominant to non-dominant communities, centering the experiences of those in non-dominant communities. So for instance, community cultural wealth acknowledges the array of knowledge, skills, abilities, and contacts that are possessed and utilized by non-dominant communities in order to thrive. Essentially, centering community cultural wealth reveals and honors all of these things in a way that creates an environment where we're not looking at communities and their outcomes as deficits, but starting to look at what assets and what wealth the communities possess and ways that we can utilize that wealth of knowledge and experiences to further social outcomes, including outcomes in healthcare. So community cultural wealth is a concept that was developed by theorist Terry Yoso, who I believe is still at the University of California, Los Angeles. And Yoso argues that community cultural wealth can be understood through at least 6 forms of capital, including aspirational, linguistic, familial, social, navigational, and resistant. Yoso notes that these various forms of capital are not mutually exclusive or static, but rather are dynamic processes that build on one another as part of community cultural wealth, and that the accumulation of assets and resources through these various forms of capital act as buffers against hegemonic institutions and practices that may inflict harm upon non-dominant communities. So, let's take a little bit of time here to unpack these various forms of capital that together form the cultural wealth of communities. All right, so the first capital that we'll go to is aspirational. Aspirational capital is essentially defined by Yoso as the ability to maintain hopes and dreams for the future, even in the face of real and perceived barriers. And this resiliency is evidenced in those who allow themselves and their children to dream of possibilities beyond their present circumstances, often without the objective means to attain those goals. And so in the context of healthcare, for instance, this could present itself as families and individuals using resourceful measures to improve health outcomes in their own communities, including community gardens to combat fresh food scarcity, midwife programs to combat lack of adequate maternal care resources, and other types of cultural-based programs within a community that allow each other to depend on each other in the community to meet their healthcare needs. And so I wanted to pose some key questions for each of these areas, right? And so some of the key questions we may ask ourselves in dealing with issues of public health are, for instance, what health outcomes really are important to this community, right? Where are there gaps in our understanding as professionals for what a community is actually experiencing and what they actually want to see change in their community? Because sometimes we go in with a different concept or a different understanding than the community has. What barriers to achieving these outcomes exist? And these barriers can be real or perceived. I argue that perceived barriers are just as significant as real barriers because they have the same effect of not allowing people to reach their full potential and have full access to the resources available. How has this community historically overcome healthcare barriers, right? Every community has a history, a story of how they've overcome challenges, right? And in particularly with healthcare, how they've been able to be resourceful within their communities and also in a way that helps them achieve different goals that they have internally. And how have they done that? And how do we accumulate an appreciation of that? And then how does a healthy community look, or what does a healthy community look like for this community, right? The idea of a community being able to be self-determinative and understand and decide what it means to be healthy for themselves. The next form of capital is what Yoso refers to as linguistic. And linguistic capital is the intellectual and social skills attained through communication experiences in more than one language and or style. And linguistic capital reflects the idea that people navigate society using multiple language and communication skills. And understanding and valuing the diversity of those skills is essential for authentically and effectively engaging these communities. This includes understanding how people talk about health and wellness and communicate their experiences. This also entails developing a deeper knowledge of the modes and styles of communication that are most effective and impactful for a particular community. So in this instance, we may ask ourselves, how do people in this particular community talk about health and wellness, right? What are some of the words that they use? What are some of the expressions and the sayings that they develop within their communities about health and wellness? And what ways of communicating are important to the community? Some communities value oral communication more than written communication, some vice versa. Some use technology very well. Some do a lot of their talking at the dinner table. And even in some communities, there are particular gatekeepers, there are particular spokespeople who are trusted individuals who can kind of be the mouthpiece for that community. And so understanding linguistically how a community communicates with each other, and then how to utilize those skills to communicate with that community is very essential for a lot of the work that we do. Right? Next, Yoso describes familial capital as the cultural knowledges nurtured among kin that carry a sense of community history, memory, and cultural intuition. Now, this form of cultural wealth engages a commitment to community well-being and expands the concept of family to include a broader understanding of kinship. Acknowledging the racialized, classed, and heterosexualized inferences that comprise traditional understandings of family, familial capital is nurtured by extended family, which may include immediate family, some living or some even long passed on, as well as aunts, uncles, grandparents, and friends. Familial capital includes lessons of caring, coping, and providing, which may foster a development of consciousness with and between families, as well as through school, sports, religious gatherings, and other social community settings. And so when thinking about familial capital, right, when thinking about this expanded concept of what constitutes family, what we really center is relationships, and those intimate, close-knit relationships that are influential, that help people develop the type of cultural knowledge that they have. And that extends beyond just knowing, but also being able to cope and being able to foster development. So we may ask ourselves questions going into communities, what stories or experiences with healthcare are passed down from generation to generation, right? Many of us are in communities where, we've developed an understanding of healthcare access and the healthcare system based on stories that have been passed on. And that can color the way that we think about and interact with the system. Also, how does family history impact views on healthcare and wellness, right? What was the experience? I know people who don't go to hospitals because their grandparent may have been mistreated in the hospital and passed away, right? And they blame the hospital. And so there are different ways of thinking about that. And then also, what family members have the most influence on views and behavior? And again, talking about family in this very broad context, who are the people who are influential in lives and can really have an impact on the way people view the healthcare system? The next form of capital that he also describes is what we call social capital. And social capital is essentially networks of people and community resources providing instrumental and emotional support to navigate through society's institutions. And so, for example, drawing on social contacts and community resources may help a student, for instance, in school, identify and attain a college scholarship, right? Based on who they know, right? It's essentially about who you know and the impact that has. These networks may help a student in preparing the scholarship application itself, while also reassuring the student emotionally that he or she is not alone in the process of pursuing higher education. Scholars note that historically, people of color and other communities have utilized their social capital to attain education, legal justice, employment, and healthcare. And in turn, these communities of color gave the information and resources they gained through these institutions back to their social networks. And so some of the questions that we may ask going into a community pertaining to social capital could include, what are the trusted institutions in this community? And how do we build trust with those institutions? What types of support are most valued and effective within this community? And who are the gatekeepers? And how do we work in partnership with them to advance health access and equity in this community? Now, the next form of capital I'll discuss is navigation. Navigational capital refers to the skills to maneuver through social institutions that are not created with non-dominant communities in mind. Now, for example, strategies to navigate through racially hostile university campuses draw on this concept of academic invulnerability, or students' ability to sustain high levels of achievement despite the presence of stressful events and conditions that place them at risk of doing poorly at school and ultimately dropping out of school. And in addition, resilience has been recognized as a set of inner resources, social competencies, and cultural strategies that permit individuals to not only survive, recover, or even thrive after stressful events, but also to draw from that experience to enhance subsequent functioning. And so indeed, we see that people of color often draw on various social and psychological critical navigational skills to maneuver through structures of inequality permeated by racism. Navigational capital thus acknowledges individual agency within institutional constraints, but it also connects to social networks that facilitate community navigation through places and spaces, including schools, the job market, and healthcare and judicial systems. So some of the questions that we may ask when thinking about the navigational capital of the community are: what practices have been successful in connecting this community with healthcare? How has this community experienced navigating the healthcare system in the past? And what skills have they developed to help navigate the system? And how might the system be changed to better accommodate and engage this community? And so lastly, I'll talk about resistant capital. And sometimes we don't really think about resistance as a form of wealth, right? We don't often think about resistance as an asset. Again, I have a 5-year-old, and when she resists, I do not think of that as a positive. I think there's no way I'm in favor of that, right? But when you talk about communities, there is a lot that can be gained in terms of the cultural wealth of a community through resistance, right? So when we talk about resistant capital, we're talking really about the knowledge and skills that are fostered through oppositional behavior that challenges inequality. So for instance, we're talking about maintaining and passing on multiple dimensions of community cultural wealth, and that being a part of the knowledge base of resistant capital. So think of some of the customs, knowledge, and skills developed in opposition to oppressive conditions. We can use examples such as concentration camps during World War II, right? And how Jewish culture, much of what we know today as modern Jewish culture, emerged from resistance in those environments, right? We can think of Japanese American internment camps as well, right? And how some of the Japanese American culture we see today developed as resistance in those camps. And then we can also go all the way back to American slavery, right? And how some of the culture of Black communities in America emerged through resistance practices on plantations, right? And in communities where slavery was prevalent. More recently, we can think about some of the research, right, that shows that many African-American mothers consciously raise their daughters as quote unquote resistors, and not resistors in the way that I think some people might traditionally think about. Through verbal and nonverbal lessons, many Black mothers teach their daughters to assert themselves as intelligent, beautiful, strong, and worthy of respect, to resist the barrage of societal messages that devalue Blackness and belittle Black women. And so seeing resistance, not necessarily always as a negative, but in some ways as a tool of empowerment, as a tool of coping and as a tool of knowledge generation, when we view it that way, sometimes we can change the lens in which we're viewing how folks are interacting with social institutions. And so some of the key questions we may ask are, why might this community distrust healthcare professionals and institutions in the first place, right? How has this distrust shaped behavior within these communities? And how can we as practitioners acknowledge this history and adapt our systems to this behavior, right? So in some ways, it's like I have a colleague who talks about this concept of relocating the deficit, right? And so if we think about, oftentimes we think about communities who are non-dominant communities we see as disadvantaged as having deficiencies. But in actuality, oftentimes the deficiencies are with us as representatives of institutions and as professionals. And once we relocate that deficit thinking to us instead of them, it gives us a new lens in which to view and to change our work. All right, so now I want to switch gears a little bit to talk about community cultural wealth and corporate culture, right? And how does this all kind of translate? What are some of the things that we want to think about when we start thinking about corporate culture and community cultural wealth, and how we might transform the things that we're doing and the way we operate? I, for one, I subscribe to the old concept of culture eats strategy for breakfast. That is something I live by. It's something I go by here at my own organizations. We work a lot on culture. We spend a lot of time on culture. We spend probably twice as much time on culture as we do strategy. Because I know if the culture is not right, the strategy will never be successful. And so I just want to leave with 5 things to think about as we think about how to integrate community cultural wealth into our corporate cultures. So the first thing is thinking about moving from delivery to immersion. Right. And so, one of the things that we often do as practitioners, whether it's in the healthcare field or the social and human service field, is we often think about service delivery. Right. I want to deliver services. Well, what happens when you deliver something? You take it, you drop it off, you leave it, and you depart. Well, that's not what we're doing when we're authentically engaging communities, right? And we're understanding what communities need. And so what I often encourage my folks to do is to think about this as immersion. How do we immerse ourselves into communities? How do we become part of the fabric of that community? And at the basis of that is understanding the cultural wealth of communities. If you do not understand that, if you do not come in and take the time to learn and immerse yourself in a way that gives you that degree of knowledge, you're never going to really be a part of that community, right? And the last thing communities want is for someone to bring something, leave it, and depart. Because now you're looking at it, you're like, okay, what do I do with this? It's like leaving, a new toy, a new gadget without the instructions, without someone to call to be able to figure out how to put it together. And that's what we try to leave from. It also entails developing a deeper understanding of the ways of knowing and sense making in a community. We talk a lot about how do people come to know things? How do people come to process things? At the essence of culture is a schematic way of you organizing the way that you're processing life, right? So it's your knowledge, it's your beliefs, it's the skills you think are important to develop, it's your language. All these things are part of culture. And if we don't really understand the way that people come to know things and the way that people come to make sense of things, nothing will make sense to us as practitioners. And so how is it that people come to understand a healthcare system in the way that they understand that system, right? And really digging more deeply into that to figure out what needs to change within the system to change the way that people make sense of it. The third part is adopting a diverse linguistic repertoire, right? So we talked about the value of linguistic capital. We talk about, that being the different ways that people communicate. And for us as practitioners, it's very important that we develop a very diverse way of communicating with communities that are responsive to the ways that those communities like to be communicated with. And oftentimes what that means is having additional people on our team or additional people that we're engaging with in an advisory role, in a consulting role, et cetera, that can help us develop that repertoire, right? It's very hard to learn a new language by yourself, right? It's much easier to learn a new language when you have someone who is conversing with you in that language, right? We have someone who is teaching you, some of the different ways of talking in that language, right? It's one thing to know English, it's another thing to be able to communicate with people in certain communities, right? Even though we're all speaking the same language. And so developing that diverse linguistic repertoire is very important. And it's not something that each person can individually do. So oftentimes you'll have to bring in people from these communities to really help you understand how to best communicate with those communities. The fourth part is understanding what's important to members of the community, right? So this goes back to this idea of navigational capital, right? Of really all the different forms of capital, right? Understanding, we as practitioners oftentimes go into communities thinking we know what's important, thinking we know what's best, thinking we know what's valuable for that community to know. And oftentimes, and it's happened to me on numerous occasions, we go in and we have conversations and we realize what we thought was important is way down the list of priorities, right? I've gone into communities before thinking that, developing reading skills amongst elementary school students was the most important factor. And we had to go in and we had to come in with this great reading program. And then you get to talking with parents, you get to talking with teachers, and you get to talking with other caregivers. And they're like, well, that's important, but what's really is important is we need to make sure our kids have a safe way to get to school every day. And that sometimes just showing up is the success for the day, right? And so we really had to change our mind to maybe the intervention isn't so much in reading and literacy, maybe it's in safety and making sure the kids feel good when they enter the school door so that they're ready and receptive to the educational practices that they'll be experiencing. And then lastly, authentic engagement with gatekeepers, right? As educators and as what I would call equal partners. So we always want to search out the gatekeepers, right? We always want to search out the folks who can help be the conduit, the mediator, the liaison between us and community. But how often do we make those transactional relationships? How often do we make those a series of, you do this for me, I'll do this for you, right? If you tell me, then I'll deliver, right? Instead of making these gatekeepers equal partners in the work, right? Sometimes it means bringing them on board as employees, as members of our teams, so that we have that person on staff who not only is the face of us and the mouthpiece for our organization, but also teaches us internally as an organization how best to interact with this community, to educate us about the things that we need to be thinking about, the way we need to be seeing things if we're going to be impactful, and also, allowing them to share power with us, right? Giving them access to the resources that we have at our disposal as institutions that someone in a community may not have, and then allowing them to take that back to the community and utilize that in the community in a way that benefits the community most. So really thinking about how do we rethink our team structures, how do we rethink our personnel structures so that we have people who are representative of these communities as part of our team in capacities where they have power and decision-making authority. All right, I know that was a lot. And so in closing, what I want to do is, I know, we talked about my guy, Senator Cassidy in Louisiana, my neighbor to the south. And I didn't want to leave him hanging. So what I want to do is kind of revisit him. And I wanted to think about, if I were advising Senator Cassidy, and I was saying, Senator, I think one of the things we need to do is really think about the cultural wealth of these communities, to really think about how to authentically engage with Black women around this issue of maternal mortality. And I say, Senator, I think there are some questions you should be asking to address this issue with this community. And I think some of these questions should include things like, what are Black women saying about their maternal care experiences from their own words? How are they making sense and communicating what's going on with them, with their community around maternal care? I also think you should be asking questions about how have the experiences of Black women's mothers, sisters, grandmothers, aunts, and friends impacted their own experiences with maternal care, right? The way that they view hospitals, the way they view access to resources, the way that they view how they are interacting with the healthcare system while they are pregnant, and even after they're pregnant, and even after they give birth, right? Senator, I think you should ask the question, what sources of support exist or do not exist in this community to help improve maternal health? And how do we get those resources into these communities? And I also think you should ask the question, what can we change about the current system to help improve maternal care among Black women based on the success of other Black women? Letting Black women who have had successful pregnancies, who have overcome some of the challenges in the system, inform the system on how best to operate in order to support other Black women who are experiencing pregnancy. And Senator, I think you should really ask, what trusted individuals from this community can we partner with to learn more about this community, build trust with this community, and authentically immerse ourselves into this culture? And I think asking those questions, being able to answer those questions are really what we're talking about when we think about community cultural wealth and our work as practitioners. And so I just want to leave you with, this last observation is the work we do and the work you guys do is extremely important. I live in Mississippi, not much different from South Carolina. And I'm right on time for the first time in my life. And so, Mississippi, much like South Carolina, has some of the same issues, right? And one of the things we grapple with all the time is, are we doing things that the people we are trying to help value? And if we're not, how do we change the things that we're doing and not try to change the people, not try to change the way that they view us, change what they're viewing? And that may give them a different perspective on what's happening. And then also, how are we authentically engaging, immersing, and contributing to the culture of communities in a way that helps to achieve the outcomes that those communities are trying to achieve? So I thank you for your time this morning. And I think we have a few minutes for Q&A, and so I will open the floor.
I want to make sure the group gets some questions in, but as we, looking at the chat throughout, I was kind of thinking through a bunch of different things, and I just wanted to say, you're really giving that senator a lot of grace for assuming that he would want to ask those questions and engage with his community in the first place. So thanks for being gracious in that way. My initial reaction was to say, throw him out the window. But so I think that's important. Can you just talk a little bit more about maybe how we can get someone who makes these kind of very dumb assumptions and statements, how we could engage them a little better?
Yeah, so it's a great question. So and I will tell you what, when I did this presentation, I was being much more graceful in my professional capacity than I am in my personal capacity, because I feel a lot like you. But what I'll say is this, I've had the privilege and experience of being able to present to and have conversations with elected officials at the state level, at the local level, and at the federal level. And, one of the things that I've learned, I'm trying to be nice about it. One of the things I've learned about many elected officials is they don't know nearly as much as they lead people to think they know. And so, and the advice I've always been given by folks with more experience than that with me is, even in talking with other legislatures, is you go into that meeting, having suggestions, having things that you want them to do, right? And so just providing information to elected officials really doesn't do you a lot. What you want bullet points of actionable items that you want them to do. And you can give them some background and context, and that's what their staffs are for. But for these particular folks, oftentimes they operate in very small chunks of time. And so the more you can kind of lead them, and this is, this is in a perfect world, right? Not take into account a lot of the other competing factors that happen with elected officials. But giving them actionable items that can lead them to where you want to go is probably the most effective form of communication. In a sense of, and I don't know Senator Cassidy. I have met and I've had conversations with my senators and some representatives from Mississippi. And I think they're all kind of very similar in some ways, you have to find a way to get the people in front of them that they need to hear from. And in today's day and age, that's not always an easy thing to do.
So Laureen had a great point in the chat. Start with the people, meet them where they are. Don't make the mistake of making assumptions. There must be a personal value and benefit to the change when we're talking to our communities. I think she's saying more. Laureen, do you want to say any more about that? I also had one other question. If nobody else has anything, please put your questions in the chat. Would love to hear. I'm wondering, this is a question for the rural folks, and then Ira, because you have family from, you said Bamberg and Fairfield, right? So those are both rural counties or have a lot of rural areas in South Carolina. Do you think of the familial capital idea can be even more powerful or like a stronger, I don't know, influence in rural communities when it comes to this and thinking about access to healthcare at hospitals? Do you think that's more powerful in a rural space? That was an idea that came to me.
Yeah, so I don't know if it's more or less powerful in rural spaces. I think, I live in an urban space and I do a lot of work in rural spaces in Mississippi as well. And, in terms of family, what I've really found is the experience that an older family member has had with a system colors the way that other family members think about that system, right? So I think about like the criminal justice system, right? And I think about, I've got family members, friends, and I know people in communities who've had a loved one go through the criminal justice system and they felt like they were treated unfairly. That colors the way that they think about interacting with that system, right? Their willingness, for instance, we think about like this idea of stop snitching, right? Of snitching, right? And people are like, how could you possibly think about that? And, I had to explain to folks, like, if you're in those communities, that makes total sense because it's a safety concern. That if you're calling police to come into your community, you don't know how they're going to show up. And you don't know how they're going to interact with you and who is going to be impacted by that. And so for some communities, not calling the police is the safer option in their view. And so, we have to really understand, but if you're not talking to communities to understand that, then you'll think like, how could you possibly think that way, right? But when you do, it makes total sense. Not to say that I agree with it or not, but it just makes sense that they would arrive to that conclusion. And so I'm thinking that that's how it works out in the healthcare system as well, right? If I've got a grandmother who, died in childbirth, right? Because the hospital did not listen to them when they said they were in pain, then I'm going to be less likely to go to the hospital when I'm in pain because I'm going to think that the hospital will not listen to me, right? And that's why we see so many people self-medicate. Because for them, that's a better option than going to the hospital.
And that was mentioned in the chat a lot too, that there's a lot of home remedies and self-medication, especially in the rural areas, that are gone to first before even accessing care, thinking about the hospital system as a place for that. So
well, and even if you can't get to it, we had a woman last year in Mississippi who died on the way to the hospital because the hospital was the emergency room was she was a pregnant woman. She lost the child too. And she was a woman of means. She wasn't indigent by any stretch of the imagination, but died because she had a medical emergency and it was going to take too long for the ambulance to come and get her. And they had to drive to the nearest emergency room, which was over an hour away. And she died in the car. She and her child died in the car, right? So then you start thinking about how does that impact the way that people think about when they're going to call the hospital, right? When they're going to call the doctor. Well, they're not going to come anyway. Why am I going to call them, right?
Sure.
So we have to think about all those things.
Sure. Any last questions for Dr. Murray? I see a couple of y'all come off. I can see a couple of y'all come on the camera. That way we can take our break a little bit early and come back a little bit early and started our discussions a little bit earlier, which would be great. So Erica, Ms. Bridges, Dr. Fleming, anybody have any last questions for Dr. Murray before we move into our break? No? Okay. Well, thank you all so much. If you want to use your reactions or your chat to come up and give, thank you. Thanks, Bronnie, for an excellent presentation, sir. Dr. Murray is going to stay with us and be hopping around in the discussion rooms as well, and then help lead us in a discussion at the end when we all report back out from your breakout groups. So we're excited to have peer sharing when you get back, and I'll also walk you through the DEI project guide. So it's 10:21 right now. If we could come back by 10:32, you get an extra couple of minutes, and then we'll get started right on the DEI project planning overview, and then we'll jump right into peer sharing after that into smaller groups. So thank you all so much. Hopefully everybody had a nice
Katie, I'm not sure if you're aware, but your screen is freezing.
and show you just some basic parameters for the DEI project. So the next phase of this work is taking what you've learned in these 4 learning sessions and moving these concepts into action. So we've talked about the importance of leadership and governance and how making sure we have diversity and inclusion in our workforce and in the way that we mentor and think about not just our providers and healthcare folks, but also, you know, our frontline staff and our executive leadership. How can we do a better job of having a diverse and inclusive workforce? And that's what Dr. Carrie Claudia Allen spoke with us about. We also had an entire second session about data, using real data, making sure we're disaggregating it by race and stratifying it in a way so that we can see these health disparities that we know were exacerbated by COVID-19 and that we know are still affecting people to this day, that we've always had in America, right? So what can we do with that data? How can we do a better job of stratifying it and, you know, doing a better job of measuring what we treasure, right? So those were the first 2 sessions. And then we just had Dr. Murray talk to us about community cultural wealth. And instead of thinking about cultural competency as just making sure you speak the same language, but also making sure that you're approaching community in a way that they need to be approached and understanding the way that they think about healthcare and the way that they may think about your health system in a culturally confident way, in a way that acknowledges their community and cultural wealth. So again, thank you, Dr. Murray, for giving us some depth and some different ways of looking or thinking about cultural competency. So these 4 learning sessions, which y'all have done an incredible job of participating in, and you've done an incredible job of the data collection pieces, and we are very, very grateful for your participation thus far. We have, of course, one last session on June 22nd next month, where we're going to talk about community partnerships. But then that kind of concludes our content that we want to provide to you all. The next phase is how can we help you develop a project that has a diversity, equity, and inclusion point or purpose at your hospital that is going to affect the rural population that you serve. So that is the most important piece. We want it to impact one of these DEI metrics. And we don't want to be too prescriptive. So what we're trying to do today and over the next month or so is to provide you with enough guidance so that you know what you're doing and you feel confident pulling these things together, but that you do not, that we're not telling you exactly what to do, because you're the ones who understand and know your hospital, and you're the ones who should be able to know and understand your patient population and your data needs and your community partnerships. So that's huge for us. So these are the project parameters as we have them. We wanted to impact a DEI metric, and shortly I'm going to let Brianna share her screen, because she provided, as you saw in the reminder email yesterday, just a project guide so that you can see the type of metrics we're looking at. If you did the data sheet, you'll see that they look very familiar, and you get to define what those mean to you, what those metrics mean to you, and what that looks like to, quote unquote, for example, improve the diversity of your executive leadership team, right? So we also just want to make sure, no matter what happens, that it's justified by data. So just, y'all know this, because of how federal grants work and the way that this funding is provided to us through a CDC grant and through DHAC and through the Office of Rural Health. And the whole point is to try to make an impact on the health disparities that have been exacerbated by COVID in the health equity space. So as we know, almost everything has been impacted by the COVID pandemic. So that keeps our options really broad for these projects. But I put, as you can see in point number 2 here, we just need it to be justified by data. How will it impact and improve health equity? Just need to close the loop, make a sentence that justifies the work and that loops back to some kind of data that you've had from your hospital. And that can be from your community health needs assessments. That can be with conversations from community partners. That can be from the real data that you're pulling, or the data that you've done with your HR groups. Any of those things can be used to justify how this project is going to impact health equity and your rural residents. And again, it can be social determinants of health. It can be upstream elements. It can be like anything that impacts access to care. That's huge, right? Like that will totally count. So, and any process improvements like a data dashboard, those are internal improvements that are recommended and impacts a DEI metric. Absolutely fantastic. And it will allow you to better reach and understand your community partners who have been impacted by the COVID-19 health pandemic. So the number 3, it can be an internal or an external project. We're thinking about internal in terms of those leadership pieces, the data collection, stratification and use pieces, and cultural competency trainings within your organization. Those are what I'm thinking of as internal projects, right? That do have an impact on your ability to provide high quality care to your rural residents. And then external could be your community partnerships. So that's what I mean when we use that terminology in this context. And then we're going to have project assistance meetings in June and July. Brianna also mentioned this in her update email. We'd like to meet with you similarly to what we did with the orientation meetings at the top of this project, just to make sure we're all on the same page and that you have everything that you need to get a project plan created. I also want to reinforce big time that these projects are they're not about creating something new. If you want to create something new, please do. We can help you. We'll mold it. We'll do everything we can. You can request TA from us through the summer and the fall. There are some potential grants that we are working on for supplemental funding or financial support for some training, but it depends on the project. So as soon as we have more information about that, we will provide it to you. But what we really think is probably what's going to happen with most of you is that you're already working on something. You're already doing something with your community internally. You have some kind of project. So my first example I know out the gate would be Dr. Salinto Anderson at SELF. They came then said they want to do a data dashboard like ANMed Health has, right? Like the AHA is recommending. So how can we help them do that? And then hopefully Juana Slade and Suzanne Wilson at ANMed can help them, provide some technical assistance, and they can work on that as their DEI project. Great example. You don't have to do everything perfectly. My last point here is that we just want a plan that says the justification there at point 2 Why are you doing this? What data did you use to come up with the plan? What kind of diversity, equity, or inclusion metric are you trying to impact? And what are you going to do about it? What are the strategies? And so, Brianna, would you please share? Do we have any questions at this point? I'm going to have Brianna share her guide that she provided to all of you via email. So you're welcome to pull that up and look through it and ask questions, of course. But Brianna's going to share her screen so you can see, so she can walk you through that part. So please, oh, something froze. All right, are we good? Can everyone see this? Put something in the chat, I can see things now. Okay, yes, it's working. Thank you, Kimberly. Thank you so much. Great. All right, so Brianna, do you want to walk folks through what we're thinking with this project guide quickly?
Sure. So with this project guide, we intend that each hospital is going to be using this to kind of lead your brainstorming and your planning of your DEI project. It has been broken up to make this a little bit more simplistic. So it's just taking you step by step, 1 through 4, to help you with creating that. So step 1 is just going to be selecting your project topic. So again, just based on those domains that we previously identified, leadership and governance, data, cultural competency, as well as community partnerships. Now within each of those, you will see some kind of almost measures listed. These will be very similar and kind of correlate with the data, baseline data that we collected a little bit earlier. So this can easily be inputted and used to measure and track your progress throughout your project and its evaluation. A little bit lower, we're going to be looking at identifying community partners. So once you have identified what you plan to do, what you plan to work on, we want to see how you plan to accomplish that. Who do you think will be able to assist you and help with that project and its implementation? Next, we'll be talking a bit more about identifying your goals and objectives. So once you figured out who is all going to be on board, what exactly is it that you are going to accomplish, and just laying out those objectives to follow along with it. Now, I know that a lot of space is listed here. Of course, you don't have to have as many goals that are listed. We just want to make sure that you had enough space in the case that you were being extremely ambitious and wanted to make a lot. Down at the bottom, is going to be talking a bit more about measuring that success. Again, you can use baseline data just to see what your starting point is, and then setting those goals for the future. What do you think that's going to look like later on this year? What do you think it'll look like coming next year, 2023? And you can use both your baseline data as well as any additional data that you may have within your hospital or hospital system. Now, down at the bottom is going to be talking a bit more about the Turn the Curve action plan. Now, all of these questions are going to be based on the results-based accountability framework, and I'll be sharing a few links in reference to this in a few minutes. This is just going to be talking a bit more about moving from talking about that problem to creating action for those problems. So this can be used during that brainstorming portion. This can be used whenever you are meeting again with your teams to figure out where do we go from here. And we can also talk with you about this when doing those TA sessions, that we can be giving you further guidance and helping you with that brainstorm portion as well.
Beautiful. And like Brianna just said, those Turn the Curve questions are just great suggestions. They're based on that results-based accountability model from Clear Impact. And we can provide some guidance there, but they're not required. We just want to make sure you have some help when you go back and meet with your team, or when you're thinking about this as a team leader, that that it's not just check off all the boxes. There are also there's some nuance to these questions that help you turn these basic pieces into some real action. So thank you, Brianna, for that overview. Is great. I'm going to share the screen. Last time we would like to have the plan, some sort of plan. It doesn't have to be perfectly filled out in that project guide that Brianna just provided. You can put it in any format that you'd like, and we'll reiterate this at our project assistance meetings, but just letting you know, we would like to have something by September 1. And just like with everything else with this project, if you need an extension, if you have extenuating circumstances, please let us know, and we'll be happy to work with you. And we'll be happy to set up times or Zooms or whatever you need in order to get your group together to do this in a efficient and impactful way. So Brianna and I are here to help, as well as the TA team. So do you have any questions about the next phase of this project as we move forward? Great. I must have explained it perfectly. Thank you, Brianna, for creating such clear instructions for all of us. And if you think of something after or during this process, please make sure you write it down so that I can, so we can address those later, because I know once you get into it, you might get questions. So happy to do that. So Amanda, are we ready to move into our peer learning part of our session today? I'm really excited to give y'all some time to talk to each other. So for example, we know Spartanburg is already doing so much of this work, right? Spartanburg Regional Healthcare Center. We want y'all to be able to talk to the other systems and hear what issues they're having and maybe help them problem solve. So today, what we want to do when we break out into groups, and I'm also going to be able to share this slide with you all when you break out. So you'll have this in your groups to look at, so that because you'll be in the groups for 45 to 50 minutes. So if you are, so this should give you enough time to go around. What we're asking you to do is to go around the group. There'll be about, Amanda, how many per group are there right now?
They vary depending on facility or organization.
Right, so we tried to put 2 to 3 represented hospitals that are represented in each group so that you can talk to each other. So some have a little bit more than others. We would like you then to introduce yourselves and what hospital you're affiliated with. And then you'll go around again. Make sure you identify someone to report back about what your group discussed and at least one thing you learned from the other hospital. So that's what we want each hospital to report back out. So when you're talking in your groups, our suggestion, if y'all get on a different tack and you're having a really productive conversation around health equity successes, health equity challenges, and you're not, and you're just having a really productive peer sharing conversation, please continue that. We want to hear that. We want y'all to let these happen organically. But if you want a little bit of structure to the discussion, you can do these different breakout instructions. So you would have share a bright spot or a successful strategy or program that your hospitals use that you want to highlight. You're like, this really went well. This really worked. We didn't have a connection with, say, migrant farm workers in our area, and we were able to reach out to them through this, where we didn't have any of them accessing our healthcare services before. Right? Or we did outreach to so-and-so to this church faith-based community, and we're able to get some community partnerships going that way. So share a bright spot or successful strategy. Or any kind of internal strategies. You've had this type of competency training or unconscious bias training, and that's really helping your physicians or your people to have a better interactions with their community, their patient population. Then you would go around and each share a challenge or something that you need assistance with, and then you can have a discussion about what might be a good tactic to address it. And then discuss amongst yourselves what could you replicate? Is somebody doing something else, have a program that you feel inspired by, that you think that you could replicate at your institution. So I hope that this can be a healthy dialogue for everybody. Do we have any questions about the breakout before we put you into the groups for about 50 minutes? All right, Amanda, take them away. Thank you guys so much.
Are you going to be sharing the instructions to?
So I'm going to share this screen to the groups as soon as they're in there.
Okay.
Right? Okay. So y'all should have this screen to refer back to. Thank you all so much. Wonderful. Hi, Thias. Did y'all have a good conversation?
Yes, and you know, when you have good conversations, it's hard to narrow things down. So I told them I'll do my best.
All good. Are you the reporter? Good.
Yes, I think I
Love
was,
it.
we just didn't get to me. There was lots of discussion before I started, so, yeah.
There are larger groups. We tried to get in there, but we just didn't, we wanted the hospitals to be able to talk. So hopefully.
Oh, yeah.
We had some great conversation. Oh, well, I have a companion.
Yeah.
Wow. All right. So my cat Bogey is joining us for this conversation. Welcome back, everyone. Working from home and Zooming is fun. I'm looking forward to hearing what everybody has to say. Who would like to start? And do y'all need me to put the instructions back up so we can talk about what we want to report out? I'm assuming you were looking at them for 50 minutes, so I guess you're probably pretty familiar.
Yeah, it's
They're
still there.
on the screen.
Mhm.
Okay, great. Please excuse me. So Ira, who wants to start? We had 3 different groups. We had Tidelands and Spartanburg, MUSC Kershaw with Williamsburg and Self, and I know there were some other folks scattered in there as well, and then Abbeville and MUSC. So who's
This is Thias. I can go first.
Great. Okay, Thias, tell us
Yeah.
who was in your group and what y'all talked about and something y'all learned, one thing you learned from each other.
Okay, yes, so I had members from Spartanburg Regional Hospital System in the group, Abbeville, and MUSC was in our group. We had a great discussion. Dr. Garrett had began by just sharing that the spotlights for her was the unconscious bias training that they did. It was they created an unconscious bias training around healthcare, and it was drilled down to 2 hours, and it was focuses on healthcare disparities. And within their structure, that's how they rolled it out. They wanted to make sure they began with leadership and moved through those levels of leadership. And then at their smaller organization, they made it mandatory for all of their staff, which consisted of 300 people. And the goal was, after they had the training, they would also be able to provide help for access of health and community health just by reaching out. Some of the challenges that they're facing is just keeping the momentum going to create opportunities for more individuals of color to participate in healthcare delivery. As she said, most people are not retiring anymore, so it creates a gap with just mentoring and creating a succession planning, just to make sure that you always have that fluid employee and practitioner support where you can continue to grow and really reflect your community. She said that life inspires her, and that was really consistent throughout our whole team, that life inspires us, but education and being part of something greater than what we've been called to do have been exceptional as well. Some other things that was brought out, Abbeville, Ms. Morgan, she's the community outreach director for their department. And she talked about using her community health needs assessment and providing monthly meetings to help bring the community together to support many of those gaps that they've been finding. But what she had brought up is kind of consistent with other hospitals that's in this collaborative, that there's not necessarily one unique department or one unique workforce that is focused on diversity, equity, and inclusion. And sometimes there's a opportunity where you have conflicts or work is hindered because you're having so many roles and responsibilities that you're having to manage, and have a tendency sometimes to lose sight of the goal. You know, many times it's not enough people and not enough time to really accomplish all of those issues or challenges that we are facing. Now, MUSC highlighted that they actually do have a team, and it's great because they're able to really focus on those opportunities and the needs that are occurring, because they know that diversity, equity, and inclusion is not just in one area. It should be moved throughout the organization, moved throughout the community for success. I wanted to say one more thing. Ms. Kennedy had reported out that what they have been able to do was really bring the community inside the organization. COVID actually was thought to be a divide in healthcare over the last 2 years, but what they found is COVID actually brought people together, because you were able to really go out in the community and really figure out what were the needs of the community, and you're going to meet those needs of the community. Again, providing opportunities where you can educate and inspire others and teach our community for understanding. So when we talk about one thing that we learn, of course, with all of these opportunities and conversation, it really wasn't one thing, but it kind of meshes all together. So the one thing that we learned, we have to have collaboration, partnership, and relationship building to make sure that we get things done and be able to be comfortable asking for what we need. We want to make sure that we ask for help, because it's going to add to the evaluation process, and it's going to encourage others to partner and do what's been asked. And Dr. Murray had joined us briefly too, and he had shared with us the 211 information. We're going to use that data to use for baseline information, baseline data reporting. And it's also an opportunity where we can get a glimpse into our community to see exactly what those concerns that are important for those people in the community, because they're calling in and they're asking for what they need. And that's another resource that we can use for data. So thank you. That was a lot.
No, that's perfect. That's a lot. Does anybody from that group want to share or add anything else? Ira, is there anything? Thias was thorough for sure, but is any other comments, or does another group want to piggyback off of those things?
Well, I'll go next. I know we're kind of running out of time, and our group had a really lively discussion. So some of the bright spots, and we covered, I guess, from the PD to the Midlands area. The bright spots are that Lauren in the McLeod area had a more focused workflow in their health system related to food insecurity, and they have a work plan that they're going to be finalizing by December of 22. They also expanded their maternal and infant health with self-pay, and they're looking at their family medicine outreach in a couple of their more rural communities. And then Jessica shared a really awesome bright spot in the Sheldon area with the Mount Carmel Baptist Health, and they have a mobile health clinic that they actually repurposed into a dental clinic, and they're utilizing the church access into the community. They also have some addiction medicines in the Beaufort County, which is helping with those addiction issues and providing support and education and medications. And then I just mentioned in the Midlands area, the bright spot for us connecting to MUSC was a 4-hour DE&I requirement that's built into our modules for care team members, and they can select which area of DE&I they have an interest in, so that they sort of tailor their education and where they are. And so I think that's important. Quentin was sharing that in the MUSC, the last 2 years with their pandemic response has been great, because his group has been able to get out into all 46 counties with vaccine and testing for the rural health strategy. And so that was a really cool opportunity, again, to take COVID and turn it into something positive. And then we had, Dr. Willette Burnham-Williams was talking about how we're looking at a more inclusive rural community outside of Charleston and taking those best practices and throwing them out into the whole state. So that the one thing that also can be a challenge from her perspective is how you take that excellence standard and apply it to each of those rural communities. So while we know we can do it in an area like Charleston, can we also replicate it so that that standard serves all communities equally? And then we also looked at a bright spot in the MUSC system being their data and prioritizing their data for process improvements and their approach to work so that we can measure the impact and the return using that data literacy and strategy as a full inclusive process. And so we have access to a lot of data and then using it to actually make decisions and see how that impacts our outcomes. Deneen from MUSC also had shared that DE&I training from the enterprise out using definitions that mean the same thing across all of MUSC Health. And also they were very happy that LGBTQ Health had a summit and it shared goals and objectives looking at marginalized groups, whether they're a care team member or a patient, and being able to share what access means to different marginalized groups and how others outside of those groups can have a better understanding and educational awareness. And then Kimberly was also with MUSC group. I guess our group was a little heavy with MUSC, but it's a large group. And so we had a lot of good topics there. So from her patient outreach and recruitment, they actually back in prior to 2020, MUSC in their EMR had an opt-in opportunity to be included in research. So their research team could only talk to patients who opted in for research. And that really left a lot of people on the outside who didn't really understand the process. So after 2020, MUSC's EMR switched and now it became an opt-out. So essentially everyone was included unless you read a little further and chose not to be included. And so that really has given their research team more access for patients to participate in research opportunities. So then we switched our topic over to challenges, and we all just agree that for most of the day we're drinking out of a fire hose. We have a lot of competing priorities in health systems nowadays, and so Dr. Willett had made a comment about culture eats strategy, and so that is certainly something we've all heard, and it is true because we get fired up in conversations like this, and then we tend to run into barriers because other leaders have different goal sets and focus areas. And so it's just challenging to break down those barriers. Lauren had talked about access, health, and PD. So there's pockets and cultures, and how do we learn the everyday language to have an open mind and an open heart so that people that are in healthcare, that are in different positions should say, you know, I want to know, I desire to know. And that really connected with something that Quentin was sharing and something that as our team came to, what is one of our top things we'd like to share back to the overall team is to have a heart to come and meet people where they are and look for the connective tissues that bring us together. So he was saying that from his perspective, his success for his team has really been driven from his ability to make his work personal, and that he loves the state and he loves the people. And so when we are able to find people who can lead from the heart, and that heart graphic was really interesting because it just goes back to fundamentally loving humanity and loving people. So going with that mentality makes us all feel like, can we find people who lead from the heart and do it because it's the right thing to do? So it's not always focusing on the bottom line, but what can we do as an organization and a collaborative to really meet people where they are because it's the right thing to do. So I hope I didn't take up too much time, but that was our group discussion.
I think that's fantastic. Thank you for all of that. I know they were large groups, so I'm really glad y'all were so thorough about reporting this back. I'm trying to take some notes in the chat just so we have certain things. So those of you who have reported out or were in those first two groups, make sure to check me and that I didn't get anything wrong with my notes that I'm taking. All right, so we have a final group to report out for about if you can do it in 3 minutes, that would be ideal. We're also going to start putting the meeting evaluation up. I'm going to share that slide so folks have that info. But who's our last group?
Is that going to be us? It was again the Thailand Spartanburg group.
I think so.
Okay, all right, not sure because it would sound like we had like two Thailand groups. Okay, we had a pretty good discussion, and it ranged pretty widely. And I think we started LaShondra from, I think she was from Spartanburg area. She shared the success that they were having with a program initiative that they had to serve the diabetic population, and where they had lifestyle coaches to provide that service. And the question was asked that how did they fund that? And they were able to get a grant because they had people, they had relationships with community groups and members that had expressed an interest in such a service, but they couldn't do it. So they were able to get a grant to train these lifestyle coaches to help work with patients to improve their health. And one way that they assess the needs of their community, which is a little bit different than I think what we do here at Tidelands Health. We do have surveys that the community can fill out. They actually do focus groups, and that allows them to get down into the weeds a little better and get into the details of some of the broader issues that are important to the community that they serve. Chrissy she had Cherokee and Union area, they noticed that one of the biggest barriers to healthcare was transportation. So they are, and with that, the ED becomes the primary care giver. And I think a lot of systems experience that. So that is one thing that they are working to overcome that barrier. And one of their resources was referring to Access Health, and patients have assistance with financial assistance and prescriptions and things like that. And LaShondra suggested that another possible resource for the transportation barrier were the local council on aging. I know that we have one here in Georgetown County and in Myrtle Beach, and I'm not sure how much assistance that they do provide, but that's certainly something that we can look into. And there was a lengthy discussion with Jennifer about how COVID impacted our system, and may have, because of our initial response, it was new to everyone, impacted the community's willingness to trust us as an organization for the healthcare of their loved ones, because we were learning how to treat the disease and learning about the disease. And she said one of the things that she hopes would help overcome that was the institution of the use of the iPads to be able to communicate between loved ones and family members.
Love that. So
life. And it sounds like it was a game changer for us because they were able to bring in multiple family members to speak with their loved ones. So
that's building relationships with the community by providing a service and having them, that's huge. I love that.
Yeah, absolutely. And Monty came in and asked some questions of us, and there were responses. And one thing he was able to highlight from that was the intersection of some of these groups. We have LGBTQ groups, which LaShondra had identified that they were doing some work impacted in her community. How that intersects with other groups, or even, like a race, you are part of the LGBTQ plus group. And then you are also impacted by race disparities and access to care or inability to access care. And it's like being hit twice. And so we need to be aware of those intersections it's almost as if you have a new group to be able to address their needs and hopes and aspirations with regard to healthcare.
Awesome. Wait, I'm so sorry. We only have 1 minute left. If you could put the rest of the results in the chat. I just want to make sure we say thank you to everyone, and have come off and say thank you to Dr. Ira Murray We really appreciate this really lively conversation. We're going to continue this in session 4 and make sure you have time with each other. You'll also be hearing from Brianna about having these TA session meetings. So group leaders, please make sure you're looking out for those. So thank you all so much for being here, and snaps to all of you for your hard work in your communities. These are such great bright spots. Thank you all. Thank you, Ira.